So I'm joined today, this is a launch event for a new product on the market made by Contura, and it's called Arthrosamid. I'm joined by Professor Henning Blidal, who's a professor of rheumatology in Copenhagen, very much involved in clinical research, and he's got a long background of using this product, and he'll tell you a little bit more about it. We'll also hear from the Chief Scientific Officer from Contura, Dr. Eva Ankarina Stark, who will tell you more about the scientific basis for the product. So there's pictures of each of them so that you recognize them when they stand up. The problem is that osteoarthritis is on the rise. This is a meta-analysis from the Lancet from a couple of years ago. And admittedly, there are countries where there is very little data, but it's on the rise. It's occurring in younger people with a rise in obesity, with people living longer. It's growing as an issue. That's the reference if anyone wants it. I can put it back if anyone wants it. And the older you get, the more likely it is to occur. So as you get older, a bigger cohort of your patients will have this problem. And currently, we can treat the problem with a variety of solutions. I kind of tell my patients that, broadly speaking, the domains of treatment are physical, chemical, and surgical. I'm a surgeon by trade. I enjoy doing operations, but it's by far the treatment of last resort, not the treatment of first resort, unless their knee is already completely wrecked. So you should, with best practice, discuss the alternatives. You can physically tell them to lose weight. You can prescribe an exercise program. You can give them a walking stick, but that doesn't get you very far. Chemically, there's gels, tablets, and injections. And then obviously surgically, there's a variety of treatments from trying to restore the articular surface, to replace the articular surface, to offload the articular surface. And I'm not going to go into the surgical options because that's a whole level above. This is talking more about non-operative management. Physical or pharmacological, there's things like glucosamine, food supplements, initially used in animals, now used in humans. It works for some, it doesn't work for all. Gels, not that effective. Tablets, side effects to all of them. No treatment that I can think of has zero side effects. So you have to weigh that up, the benefits given to the patient versus the contraindications. And then obviously there's various injections on the market. Corticosteroids, fairly short action, maybe cytotoxic. Henning is going to talk a little bit about the potential side effects and the data on that. Hyaluronic acid derivatives, different products on the market, different profiles, but they are useful. They can last up to 6 months, depending on which product you're using. And again, some of the products are single injections, some are a course of injections. Activated platelets and stem cells, we're very excited about these a few years ago, but certainly in the UK, progress seems to have stopped. And often it's just used as a marketing tool to get people into the clinic. Certainly in central London, that seems to be the case. And I'm not going to go into any great detail, but I certainly haven't been convinced by the long-term evidence of the benefits of using biological treatments. And that's not the rheumatologist biological treatments, but biological treatments in enough there isn't enough data for me to tell my patients to spend their own money on it, because I wouldn't spend my money on it. I'm going to stop there because I'm kind of chairing this session. I think we'll talk, Dr. Ankarina Stark will now tell you a little bit about the scientific basis, and then Dr. Henning will talk about his personal experience and the data behind the product.
Hello, everyone. I think it's a historic moment for a company today launching our product, which has been kind of my baby. I'm by training biologist, and I joined Contura about 20 years ago and started developing this product for different indications. So Contura is a medical device company. It's headquartered in the UK, and manufacturing facility and development happens in Denmark. We manufacture, develop, and commercialize hydrogels for various purposes, injecting into soft tissues, for augmentation of for wrinkles or when reconstructive purposes, also for incontinence treatment and for osteoarthritis. The company is established in 2000, so it has more than 20 years history of knowledgeable and manufacturing the gel and also understanding the biology of the gel. Contura's development manufacturing facility is purpose-built and situated nearby Copenhagen. So our products, we're talking today about Arthrosamid, which is a long-lasting intra-articular injection for symptomatic treatment of osteoarthritis, has been just approved this year for marketing in Europe and the United Kingdom. There's Bulkamid, which is injectable for urinary incontinence treatment. It's been PMA approved, and recently we sold that business part to Axonics Modulation Technologies, American company. As I mentioned, there is Aquamid, which is a product for soft tissue augmentation for reconstructive purposes of the face, for instance, the nose bridge augmentations and so on. And Arthrosamid Vet, a long-lasting intractable injection for animals and specifically equine and canine species, which have been in use in these animals since 2009, so more than 10 years already. And more than 10,000 horses have been treated with excellent results. So looking at the history of development of the material, it's more than 20 years now since we started to work with the gel. We've done a lot of preclinical testing, biocompatibility testing, and to understand the material interactions with the tissues, it's very important to have a pathological examination of histologies. And the first work we've done in intra-articular injections were some rabbits around 2005-2006, where the healthy rabbits were injected with the hydrogel. Initially, we're looking at that as a pure lubrication, but after 12 months study, we could see that the material becomes part of synovial membrane. And in a minute, I will talk about that a little more detail. And the rabbit experiments encouraged the veterinarian to try that in a cat, and the cats who were overweight and limping suddenly could run and jump. It was a great experience. Ended up with veterinarians starting to use that in equine species. And here the first horse injected actually was a life-saving treatment. The horse was on the way on a slaughterhouse, and after Arthrosamid vet injection, it actually came number 4 in the race 2 months after injection. We've done also some experimental work in the goats, looking at an experimental model of inducing osteoarthritis, how it works. And also then the veterinarians have also some humans working with horses who could see the good results in horses and wanted to have the same for their needs, and some compassionate use started around 2010. We've done the gel here is injectable hydrogel, which consists mainly of water. So it's a polymer of 2.5% dry matter, which bounds or swells in the water. It's homogeneous, there are no particles. It's biocompatible, as many of the studies done, and becomes integrated with vessel-bearing network in tissues, and as soft tissues and intra-articular tissues, where the soft tissue is there. And exchanges water with surroundings, so it's not closed, a dead area. It gets exchanged with the surroundings with antibiotics or other substances, and can then come into the gel. And the rheologic properties resemble actually the properties of normal synovial fluid. We have, as I mentioned, 20 years history with excellent results for different indications and a good safety profile. This is just the overview of the tests done. So there are biocompatibility testing according to standards, some specific bench testing, so we understand our hydrogel pretty well. What happens in the tissues is, then on the left-hand side, you can see that there the schematic drawing of the gel being injected in the tissues, and those blue dots should example the macrophages. So attack a foreign body. The foreign body has been attacked, but as macrophages cannot digest the hydrogel, it became exchanged to fibroblasts and become integrated part of the tissues with no inflammatory cells. Here you see the electron microscopy picture of the cryofractured hydrogel, and this is a horse coffin joint 2 years after injection. The blue is a hydrogel, and the pink is a connective tissue, and you don't see really inflammatory cells here. Also an experimental caprine model. This is a gel sticking here, adhering to synovial membrane in a joint. So in the tissues with synovial tissue after injection, the gel injected in a cavity becomes immediately interspersed with synovial tissues, synovial cells who segregate and multiply and start entering the gel. And here on the right side is the control with it in saline. After 3 months, this hydrogel now becomes part of the synovial membrane with new intima layer on the outside of the gel. So thickening the membrane of the synovial membrane. But compared to thickening of synovium due to inflammation, where you see inflammatory cells, including lymphocytes, monocytes, plasma cells, the gel's thickening of the membrane is benign. There are no inflammatory cells and very, very few macrophages or giant cells. So those effects in joints have been studied in different animals, like rabbits, horses, goats, and humans, and those data are published, showing that there's a response which does not contain any significant inflammatory response, is not ongoing granulose response, and that deposits of hydrogel become integrated into the tissues. In the horse joints, we've done a lot of clinical studies showing that actually they're good result with thousands of animals treated and no complications emerged. And equine studies demonstrate a long-lasting effect. In a single injection, showing that at 24 months, 80% of the horses are lame-free. Like seen here in this graph. So the blue would be the lame-free. And interestingly also that initial effect is getting better with time, starting with 3 months around 60%, and the 24 months result actually is about 80%. And also interestingly is that joint effusion scoring is decreasing at 24 months. There are no effusion literally. And the gel also has effects in humans, which was mentioned before, compassionate use in humans since 2010, with several hundred knees injected. And there are some clinical studies demonstrating those good results. The analysis of compassionate data with 100 patients, open label study with 50 patients, and so on. And Professor Blidell will discuss the clinical data in more detail. So in summary, it's been actually the hydrogel has been in human use for various indications since 2000 and has a good safety profile. Bench and biocompatibility studies, as well as literature, show that there is excellent biocompatibility. Our rheological properties of the hydrogel is similar to normal synovial tissue, and it becomes integrated in synovium with enmeshed with fibrous-like synovial cells, originating from synovial membrane. And we have demonstrated in clinical studies, both in humans and animals, it significantly reduces the pain, long-lasting. Thank you. And then I think Henning will continue the clinical data.
Thank you to the organizers for letting me present to you some of the data we just heard of, and especially to be able to take off the mask for a while. So, and thank you for listening. What I'm going to talk about is this polyacrylamide hydrogel and the intra-articular injections having been performed in various ways. And these are my disclosures as to relationships, associations with various companies. I also have to disclose that I'm a rheumatologist. I'm not at all into orthopedic surgery, and actually most of my time is used to try not to have my clients into your hands. These parts are the outline of the session. And here there's a very busy slide taken from a review in OASI, the journal Osteoarthritis Is, a couple of years ago, of non-surgical interventions. And there are so many, you don't imagine the lengths people in my outpatients clinic will go to not to get into surgery. So it's an endless line. And of course, if you had one very effective treatment, it would outsmart all the others. A review again from Osteoarthritis and Cartilage, the OASI Association had their guidelines, and while doing this, they asked colleagues about their inclination towards various treatments, and as can be seen, top of the list almost will be steroid, intra-articular corticosteroid injections. Everyone favor them. They are effective. That's my view also. I give thousands of these injections, but I'll just review some of the evidence with you for this. And this is a beautiful study a couple of years ago from the States, a very well conducted randomized study. Everything is good with it, blinding, etc. And they were randomized, these 140 participants, into saline or corticosteroid, as you can see. And they had an injection every 3 months for 2 years. And these are the results for pain, you can see, as detected by the WOMAC. And in the beginning, the steroid has a bit better effect than saline. But after that, for all the other injections over the 2 years, they were exactly parallel. No effect of the steroid on top of the others. Actually, we planned to do a similar study, but after this, we dropped it. What is a bit disturbing is that the MRI studies they conducted on these 140 participants showed that the steroids significantly accelerated the degeneration of the cartilage. The saline group lost 0.1 millimeter of their cartilage during this 2-year period, and the steroid group lost more than double of this. So it accelerates the degeneration of cartilage when you use steroids repetitively, and the only conclusion you can come to after this would be that the steroid injection should be limited, and it seems that it's actually a one-time offer. After that, you will give your patients some nasty drug, causing them to lose cartilage. Instead of the corticosteroids, as just reviewed by Sean, we use a lot of other injections. And this is simply because doctors love injections, and in common for all these substances, all these interventions, is that they are short-lasting, it's degradable substances, and you don't see any very long-lasting effect of it. Even some of us, having tried stem cells, must realize that at present it seems that, according to animal studies, the stem cells are gone from the joint after 2 weeks. So there's no lasting solution with stem cells. Then what about the polyacrylamide? We just heard from Eva that it has a lot of advantages in various tissues, but in my view, the most interesting about this substance is that it's non-degradable, it stays in the joint. So of course you will have to use an injection technique that is safe and sure to place it in the joint, but apart from that, it will be a potentially long-lasting and everlasting effect of the joint if it works. So the results of this, first of all, we had the chance to recall a number of patients having been treated in a specific clinic in the area. And this is the name of the rheumatologist who used it, I believe, for the first time in humans. His clinic is in northern Zealand, north of Copenhagen, in an area where people have a lot of horses. So he started treating the horses' owners with this horse drug. And he did it for some years, and we had the permission and the chance to review and recall some of the patients. 84 that was, and here they are. You can see that this is people in their 60s. They are mostly women, in my clinic, 2/3 of the patients are women. They are a bit overweight, quite common in our district. And as you can see, interestingly enough, the distribution of the joints with the Kilgallen-Lawrence grade were at all grades, even what we should say, the bone-on-bone radiographic signs were not taken out of this study. They had fairly large WOMAC scores at the baseline, and you can see the changes we detected. We did, due to the retrospective design, a 4-month, a 7-month, and a 13-month follow-up on these people. And you can see that the WOMAC changed for the better in the range of some 8 to 11 points, which is quite significant, and this is extremely interesting results. So based on this recall retrospective study, we participated in further studies. Here the safety profile of, the recall, and you can see that the only significant adverse event is actually a sensation of distension of the joint in the days after the injection. This is not a lasting adverse event. So here are the results of a prospective study performed in 49 of our own patients in the clinic. The objective of this was to see what happened after a single injection, just a one-time injection of the PARC using 6 mL of this product. It was all given to the same kind of people as in the retrospective study. That is, we included the grade 4s of the Kilgallen-Lawrence as well, fairly distributed in 2, 3, and 4. We used, now this is a safety congress, we used a pretreatment because this was, should we say, an unusual substance to us, a bit unusual treatment with a non-degradable product into the joint. So we pre-treated a couple of hours before with antibiotics. And finally, you will have to realize that you have to change the syringes, so you will have to do it in a way that's, again, safe for the patients. To be able to prove that the PARC actually was intra-articularly placed when we had given the injection, we used ultrasound as proof and guidance for the injection. So here are the adverse events. Again, a sensation of swelling and what we call arthralgia was happening, as you can see, in a number of patients, but none of it had a duration above the first week. As for the effect, it was detected by the WOMAC again, and the pain score dropped over the first month and then stayed stable, significantly better than at baseline for a full year. You can see the numbers of people being compliant to the program down here, and we had very few dropouts. The same was seen with the other two dimensions of the WOMAC, like stiffness and function. You saw a drop in WOMAC over the first period, and then stable results for the first year, which is quite exciting actually with a new product. So in conclusion, the PARC is a promising substance for intra-articular use. Mode of action, we heard from Jeva, it's presumably on the synovial membrane. It's not on the surfaces of the joint proper. We have clinically significant effect demonstrated in the studies I just reviewed, even after 1 year of follow-up. We have very few side effects, and it seemed to be a safe substance to use after these. And finally, we should confirm the results in randomized control studies. I didn't include this in these slides, but we are just, as we speak, finishing the follow-up and the examination of an RCT comparing the PARC with Synvisc 1, a hyaluronan product. And you'll hear from this later on, I believe, in a year or so. Publishing times get longer and longer, but we will present it at the UASI Congress if any of you go to this. So thank you for the attention.